I would like to introduce, and it's a great pleasure to introduce Dr. Ravi Narayan from Sochara. He's a community advisor over there. So Ravi, I would like you to take over and present the keynote address for this session. Thank you.
Friends, it's a pleasure to be here with all of you and to share and to hear and to interact and participate in this session, which is all about community. I think the earlier session, which some of you may have attended, was like building up the context for this session, because we're talking about local actors, and I think it's interesting that we now move to the... I shall not go too much into any sort of introduction. What I've tried to do in my presentation, and though it may be full of a lot of colorful pictures, is basically trying to make 5 points. And these 5 points I hope will then further be sort of contextualized and responded to by the three presenters, because all the three issues that they are raising are very much linked to, I think, the debate that is evolving in health system circles as to what we understand and from what lens do we look at this whole issue of community engagement, community participation, and so on. Now, I'm not too sure. I'm not used to holding the mic in one hand and this in the other, but I hope I'll be able to synchronize. If I can get it. Oh, sorry, what am I doing? Oh. No, I've got it here. Do I need to have? That would be easy. Thanks. Put in my pocket. Can you hear me? Can you hear? Is it? Or do I need to put? Huh? Okay, fine. I'm in a very happy position now after 40 years of both activism and professional work as a public health consultant, very involved in primary health care, to be advisor of two organizations. One is, and both of which I was helpful in co-initiating. One was the Society for Community Health Awareness, Research and Action. Since 1984, we have been preoccupied with the whole issue of community health, and this theme today of engagement with the community is very much at the heart of all that we've done. And somewhere along the line, in 1999-2000, we participated along with a very large number of people both in India, about 23 national networks in India, and a very large number of groups to evolve the people's health movement. And I am now in the unique sort of position of relaxedly advising both these groups and coming for such meetings and trying to share lessons, questions, paradigms, dilemmas arising out of this sort of 30-40 years of work. I would like to just basically say that when we look at the issue of community engagement, it's very central to the theme of both what Sochara and PHM have been doing for years, and that is that we are trying to bring the community back into primary health care, the public back into public health, and the people back into the health policy discourse. And today we'll see three studies that are trying to help this rebridging of public health and health systems and health research back with the community. I was given this topic to give a quick keynote on community engagement, but I found that that's a little unusual word, because when you actually Google community engagement, you don't find much about India, because it's not a word that we use in India much or in South Asia. It is very much in Western academia that it is now begun. In fact, all the Google few points that you get are mostly from there. So I just like to emphasize once again that I have used community engagement with inverted commas just to say that that's the theme that was given to me. But in our presentation, and when I studied the three abstracts that came to me, I found that these were the words that would sort of fit in. community health in a very broad sense as opposed to public health, so where the community becomes part of the public health system, community participation, involvement, empowerment, monitoring and so on. And if you Google these words, you will suddenly come across a huge sort of body of information and going all the way back to Bohr committee. So I would say that that's a very important challenge, and I'm doing it particularly from the point of view of health systems and health policy research. I've also tried to suggest that what this team is going to do, though it is in the public health policy conference, that we are looking at two issues in this conference. We're looking at this session. While we are looking at the health systems and health policy, many of us have been concerned, and both Sochara and PHM and many of our colleagues and friends and associates and networks are associated. There's a broader issue of the link of public health systems with the larger social, economic, political, cultural issue, and what we call SCPCE, but its values there, and which is what is the theme of this conference: equity, rights, gender and so on, which must be part of the larger social context which comes into public health. And on the other side, what we do is primarily for the people, of the people and so on, and therefore communitization. And what I have shown in red there are the three topics that will get covered at least in this session. What I want to just quickly do things is 4 quick overviews. I know in a very short time it may be a bit too much, so don't get carried away, don't bother to write notes. The PowerPoints will be made available to you, but just to get a sense of it. When we talk about community engagement, many people start talking about alma ata and the use of the word community participation. But I have been invited by WHO to write a document about a real classic called the Bohr Committee Report, because in the Bohr Committee Report in 1946, much before we thought of alma ata, much before we thought of social science dialogue with health, political economy and so on, the Bohr Committee said that there should be active participation of the people, promotion of a spirit of self-help in the community, and formation of village health committees and voluntary health workers. So what the NRHM is doing, or what any of us are doing today with ASHAs and VHS, was actually mentioned in 46. So it's not something new as we all try to make out. Mudliar committee followed, and I'm going to go through all the policies just to show you that these words kept coming again and again. So it wasn't as if somebody needed to have research to find whether it is necessary, but how effective may be a different issue. Here you find that the conscious citizen has to demand and accept. Mudliar committee, though we may have some other points of view on some of the other recommendations, said that communities must be demanding health as better standards, and governments must promote health. Srivastava report talked about part-time. So right through the history of policy in India, the CHWs of the Janta philosophy. So what you have to understand is, when India went as one of the enthusiastic signatories of alma ata, the Indian representative there was going with a history behind, a history in India where already before alma ata, all those policy documents had shown that local self-government, community organizations, community supervision, accountability to community resources, all were already part. And one of the reasons we were enthusiastic about community participation. Then alma ata came around, and I think at least all of these are linked to community, but I think equity, health for all and community participation identifies this challenge that we are going to talk about today. Here was a very interesting development which many people may or may not have noticed. I think it's an absolute must that any of you in health systems, health policy should have seen this book. Unfortunately, they haven't seen. But what is more important is what I've written at the bottom of that. For the first time in India, dialogue with the social sciences started. And the Indian Council of Social Science Research teamed up with the Indian Council of Medical Research to write this document. Now, if you read this document carefully, and especially the last paragraph, the last paragraph of the last chapter, it says that if you want to really get health for all, this is the word used by researchers, professors of PGI Chandigarh, All India Institute of Medical Sciences, what I call real hard-boiled eggs of the mainstream academia, who are telling us to organize poor and underprivileged to fight for their basic rights, telling us to build an alternative based in the community and provide community health volunteers who see health as a social function. So to me, this is a very interesting move in 1981, that social science and medical research were beginning to meet, and as a result the language began to change. The national health policy immediately changed its language and talked about transfer of knowledge, skills, technologies, talked about decentralized primary health care. The 74th constitutional amendment that came up pushed this even further. Various groups worked on women's leadership in the panchayat as one of the important things. I don't know how many of you know of the Uma Prachar initiative of Devaki Jain and others, and all this led, when we were invited to be part of the Karnataka task force in health, the Karnataka state integrated policy, all the way up to NRHM. So suddenly what you have to keep in mind is NRHM represents today, I think, a culmination, a lot of policy rhetoric, a policy thing, and today it has finally, community engagement or community participation has become systematized. And one of the reasons I like the word communitization, it sounds more health systems sort of word, is today when it's a new word, it's in the health policy jargon, but when you do communitization, it comes straight into communitization in Nagaland and communitization in here. And I think what is very important, we also in the, Bala and I were both members of this knowledge commission, the mission group, and that is why you find both of us are very enthusiastic about this whole issue. I just want to go back a little bit into the fact, because we are researchers, and just go through, unfortunately what has happened is people are looking at community participation today in a sort of new health systems, health policy research, as it's widening its context. But research itself in India, at least in India, has had seen at least 6 stages. I'm not going to go into the details of that, but I just want to flag it so that if any of you are interested in this whole area, please go back to the, if not, start with Bohr committee, and you don't have, now everything is on the web, but at least start looking at the researchers, the earlier generation of researchers who looked at this. The first one, I don't know how many of you have seen this book, 1976, ICMR identified 14 approaches to healthcare which were alternative to the primary health center. I was a young assistant professor in St. John's Medical College and very much involved with this, because a little bit in green, India's first health cooperative, the Mallur Health Cooperative, was something that I literally grew, my first 10 years of my professional life was developing, building and presenting that in the ICMR. So this was very important, that these were some of the issues, and the approaches were important, that they were incorporating primary health care, community health workers were coming in, health cooperatives and so on. 1980, that was before Alma Ata, this was after Alma Ata, because primary health care had become the new buzzword. ICMR also changed and called it primary health care, and here again this was brought in. But what is most important was that in this meeting, ICMR for the first time accepted the health systems approach, the systems approach, not just health approach. And there is a very interesting line there which says that in comprehensive health care, comprehensive primary health care, at least at that time they said there should be 3 systems working together, the socio-economic system, the food system and the health system. Very interestingly, we haven't followed it that, unfortunately, because that whole ICMR initiative sort of died out. What many people don't also realize, that Alma Ata was also preceded by research. Many people know the Alma Ata declaration, but I don't know how many of you have read this research document that led to the Alma Ata. And this was a WHO UNICEF study which looked at these case studies. From India it was Jamkhed, and that's why everybody thought primary healthcare in India meant Jamkhed. I myself personally know about 1,000 Jamkheds in India, which I can name if I had the time, like the, so it's very important. And here they also came to the same conclusion, that this is very important. So I would just like to say that community health has been continuously raised and has a much wider connotation in India than, and we have done a lot of work in our study, reflection, action experiments with our whole issues of axioms and so on. The Anubhav initiative was another very important one. Vihai and Ford Foundation identified lots of community health groups, they put them together, and there was a whole analysis, and these were all some of the analysis. So I just want to say that there's a lot of work done all the way up to the Jan Swasthya Rakshak scheme, the Mitanin program, and finally communitization has really come And for researchers like you who are involved, I would suggest, I know there are people like Raman for this, for whom this all will not be new. It's very important to look for health systems policy research outside mainstream research, because there was a lot of work and that has not come. I just want to end by saying that communitization today has become an important space for all of us to study. There is even a definition attempted in the NRHM, and there is a whole series of opportunities that we can now study. Some of them are being presented here today: village health and sanitation committees, accredited social health activists, community planning, Jan Samvad and Jan Sunvai, people's tribunals and dialogue, use of local funds in various ways, and working with Panchayat Raj. So I just like to end by saying that there is a lot of research, a lot of history, and last I'd like to say that very recently, from 2000 AD, community participation is no longer seen as a management innovation. It is seen as a whole, from a whole political perspective, and that's why when I walked in this in the earlier session, Bala was just trying to tell you that working with local actors was political economy and not health management. So I'd like to end by saying that today, thanks to the work of People's Health Movement, Jan Swasthya Abhiyan, Global Health Watch, and so on, and two books, two very recent, and I'd end with that, two very recent world reports. One is the Primary Healthcare Now More Than Ever, a World Health Report, which uses this slogan itself from the, talks about how the political world and the health sector is now responding to political aspirations and political economy. And similarly, WHO CSDH report also talks about how this has to become an empowerment movement. Today, public health program. So I just like to stop here and say that we'll come to the way ahead later as a sort of concluding remark. So all I wanted to say was that there has been a lot of work. It has been sometimes outside of mainstream academia, but there has been a lot of work, and I hope after we have the three presentations, we'll come back to this. So I'll stop this, and how do you put it off? You can do it.